of pictures of this bridge. This is a different viewpoint. And the person who found it might be looking at the upper right. You can see the cable. You're looking upward at one of the towers on that bridge. And that bridge is really important for a number of reasons. I think it's important because it's a metaphor for community mental health. And we sit here today on the 50th anniversary of the Community Mental Health Construction Act, as leaders are meeting in Boston, thinking about the accomplishments of the last 50 years and where we go from here. This bridge, in many ways, represents the millions of lives that have been able to live a life in community and outside of institutions in a way that wouldn't have been possible without the services that you deliver and you provide. And yet, the Golden Gate Bridge, despite the fact that it has carried literally hundreds of millions of people into the northern side of San Francisco, has not been a very safe place. So let's talk a little bit about that. And I'm going to start, hey, let's jump right in. Hey, you got primed last night of courage, right? You got to come back from being down, and you will. Let's talk about a tough question right out of the gate. Question number one, it's a polling question for you, and that is someone who died by hanging with their hands bound behind their back and feet tied together was probably actually a murder, not a suicide. How many of you feel that's true? Raise your hands if you feel that's true. Okay, a number of people feel that's true. You know, there's a family in California who believes that's true because their daughter, who was dating a millionaire pharmacy executive, died in this fashion. And of course she didn't die by suicide. We didn't know she was struggling. This was clearly a murder. That's what they're saying. Sadly, tragically, that's not necessarily true at all. And in fact, it's not uncommon at all that an individual who ends their life by hanging does exactly this. Why is that? Why would somebody why would they bind their hands behind their back and tie their own feet? And they'd have to do it in the reverse order. So they cannot change their mind. Now, why don't we, those in the public, those in the behavioral health field, those in the medical field, why don't we get that? I want you to hold on to that thought for a moment. The sad reality is, if you study suicide, you will find that many individuals who end their life by hanging prevent themselves from being able to change their minds. It's a reality. This is false. Doesn't make sense to us, but it's false. Forbes magazine in 2010 wrote an article called The Forgotten Patient, and they castigated all of us in behavioral health. And I'd like to say they just took on community, public sector behavioral health. They took on the entire field, commercial, researchers, psychopharmacology, private practice, etc. And they said basically what we see in the field is an individual who has any kind of anxiety, addiction, depression, severe mental illness, social issues. They get a huge light of beautiful services and treatment. But when someone mentions the S word, they get kind of relegated to the side. Now, if you'll notice in this particular picture, they're not off the table, but they're pushed to the side somewhat. And the article was called The Forgotten Patient. One of my hopes today is that you'll think about the degree to which your agency, your team, or your practice has that person struggling with suicide right in the bullseye middle. Right in the middle. You know, the day I graduated with my master's in community agency counseling, I was coming back after having spent 4 years in this degree, and I was thinking, I am now a master counselor because I just got my master's in counseling. And I was on the way home having taken the 4-hour national counselor exam and really expecting to party that night and celebrate. And I walked into my town home and immediately got a call from an individual 50-year-old white male with medical problems, socially disconnected, with a shotgun, and he was going to shoot himself. My very first thought, anybody guess what my very first thought was? What am I going to do now? No, my very first thought, that was my second thought. My very first thought was, I just spent 4 years spending all this money on videotapes and practicums and internships and classes and theories, not one shred, not 5 minutes of preparation for this moment. I didn't know what to do. My next question is, what am I going to do? And I spent the next 10, 12 hours fumbling my way through. Some things I did correctly. I went back to my engagement and collaboration and connectedness, tried to build rapport with this individual. I didn't really know him. He was in our congregation. He was calling anybody to say goodbye. I asked him to meet me, and later on that evening, we finally met in the McDonald's in the back of a Walmart. The pastor's wife is pushing a grocery cart around and kind of checking in, acting like she's there doing her shopping. There's law enforcement outside, and they said to me later, "Really, David, was it a great idea to take the guy with the shotgun to Walmart?" I said, "I'm trying to figure it out here." Eventually, I did talk to him about those law enforcement officers, that we needed to go out to see them. He agreed to go to the inpatient program if I would go with him. I did. Later that evening at 2 a.m. in the morning, the psychiatrist on staff says, "I'm going to admit him, but I need you, David, to go get his shotgun and secure it so that when I'm ready to discharge him, that shotgun is not in play." Smart. I didn't think it was great. I don't know where this guy lives. I have to go find a shotgun and secure it. Suicide, you know the numbers. Roughly 40,000 individuals a year die by suicide. But SAMHSA did some research a couple of years ago that actually came out of a substance use survey, and most of us, even in the field, were surprised that 9 million Americans a year seriously contemplate suicide. It was a bigger number than I think we had thought. The number varies dramatically by state. The rate in New York City or Washington, D.C. is a third to half what the rate is in these mountain states. You can see Missouri more in the middle of the group there. It differs but depending upon your age. I wished I wasn't becoming one of the highest risk groups, older white males. You'll notice that group, its risk goes up and up and up throughout the lifetime. Keeps going up. For Native American, Alaskan Native males, that risk peaks and comes down throughout the lifespan. And you can see at the very bottom, what's that group that's significantly, they have risk, but the risk is off the charts lower. This is the risk when older. This is the risk, that's for African American females. They do die by suicide, but in very significantly different numbers. So what we have learned about suicide, and the reason we would take a different view of it, is because of really some massive changes over the last 10 years. Polling question number 2. Suicide can be prevented. Now, I am not saying that there's a right answer to this. I'm going to tell you what I believe. Top researchers differ. But these are the questions, or the answers. A, never in those truly intent on suicide. You can't really prevent it if someone's intent. B, sometimes, but only in far in advance of the acute risk. Always, but only in advance, and always up till the very moment that the person dies. How many A's do we have in the room? You can plug in on your plate. There's a little button there. If you hit A, it comes up on the... No, we don't have that, so you have to raise your hands. How many A's don't think it's possible to stop someone who's truly intent on suicide? How many B's? Sometimes, far in advance. How many C's? Always, but only far in advance. And how many D's? Always, period. Okay, so about maybe half to 60% raised your hand on D, and the rest of you didn't raise your hands. And that's okay. That's okay. Because for most of time, people who didn't believe the last response were pretty vocal. In 1975, the Golden Gate Bridge was nearing its 500th death. They had kept track. They were entering their 500th death, and a local radio station offered a prize package for whoever the winner was of being the 500th person to die from the Golden Gate Bridge. And the local community debated this. Some said we should do something, and others said, no, we shouldn't. We shouldn't put up a barrier. We shouldn't put up a net because of 3 reasons. Reason number 1. Cost too much is reason number 2. It wouldn't look good. I paid $25 million for this house that would cost $1 million anywhere else, because that is one of the most beautiful places in the world. Why would you graffiti? Don't do that to my bridge. And it would cost money. And encourage them to try. That's in the package, but that's not number 3. There's a much bigger reason why we wouldn't put the graffiti up and spend the money, is because if they're going to do it, they're going to do it anyways. They'll go someplace else or do something different. The professionals, the behavioral health folks in the community said that. They still say that. Now, Dr. David Rosen said, wow, he's a psychiatrist in San Francisco. He says, I don't know if I agree with that. So he did a survey, and jumping off the Golden Gate Bridge is one of the most lethal things you can do. It's more lethal than using a firearm, sadly. And yet, about 1% to 2% of individuals survive. So when you have the numbers that have died there, you also have a very few who've lived. And David Rosen interviewed 7 of the 10 known survivors. Now, at that point, we didn't even know, do they see a white light? Does their life pass? I mean, I know it's funny, but we didn't know. Are they even conscious during the 4-second fall? He interviewed them all. I'm going to hold on what he found for a moment. It didn't make any difference, and we kept on doing the same things. In 1978, Dr. Richard Seiden said, wow, I don't get it why nobody read Dr. Rosen's article. Maybe if I talk to the 500 individuals who've been pulled off the apron of the bridge. How many of you have been to the bridge? Raise your hands. I could get answers on this one. Okay. That rail is about to here. It's a 3-foot rail. And people step over it, and they step onto what is called the apron of the bridge. So Richard Seiden said, let me talk to people that law enforcement and emergency personnel have either physically pulled off that apron or talked off that apron. The average length of time at the point he interviewed or studied their story was 25 years between their being pulled off the bridge and him looking in their records. Now, if it were true that everybody who was going to end their life would just go somewhere else and do something different, you would expect a very large number of those that he would find in the records they had died by suicide. What percentage did he find? Anybody know? Take a wild guess. 5. Who said 5? 6%. Now, 6% in a population for suicide is an astronomical figure. But you would have expected 50, 60, 70, 100% based upon the theory that you can't stop these individuals from doing this. That research sat on a shelf. We talk about the 17-year gap between research and practice. No, it sat on far longer than that. In the 1990s, William Styron, one of our best authors in the United States history, wrote a book about his own debilitating suicidal depression called A Darkness Visible. It's one of our top authors' best attempt to convey to those of us who don't understand why somebody would bind their feet and their hands and make an attempt on their life, to understand how deep, how dark, and how painful it is. And he said, I can't do it justice. It's more like physical pain than anything most of us who haven't been through that can really understand. Now let's flash forward to 2003 actually. Tad Friend, He's not in the behavioral health field. He's not in the suicide prevention field. He's a columnist for The New Yorker. And he was interested in these individuals who jump and those who survive. And he went back and guess what he found? David Rosen's and Richard Seiden's research and those interviews. And so he wrote an article called Jumpers. And he went into great detail about all of this. And guess what? People read that article. A couple of years later, Dr. Thomas Joyner, who's if not the top researcher in the suicide prevention field in the world, out of Florida State University, his team has developed the interpersonal theory of suicide about why people die by suicide and why the answer to that question at the beginning was false. That was really an earthquake in the field in our understanding, and he goes into great depth about these questions. And then a year later, Eric Steele released The Bridge. Now, Eric is a documentarian, not in the field either, but he had read Tad Friend's article, The Jumper. And he went to the Golden Gate Bridge, went to the authority and said, I would love to do a videotape for a year of your bridge because I love the architecture. Might have told a slight fib. During 2004, he filmed the bridge for the entire year. Now, he's in the park. If you've been to that bridge, he's a mile from some sections of that bridge. He's looking at it, and you would think that someone videotaping that bridge could see those who are at risk of suicide. You can't. There are 5,000 people on that bridge in a given day. I'm talking about tourists. People are just walking on the bridge. The car traffic and bike traffic is enormously higher. He captured on film 22 of the 24 deaths that occurred during that year. He captured them on film. Now, he does believe he saved a couple of lives through contact with the emergency personnel at the bridge. He also interviewed the family, friends, bystanders, onlookers, safety personnel, everyone involved. Now, when this film was released, the suicide prevention community went, oh no, this is a terrible snuff film. It's awful. It's terrible. We should never show this film. This film did what 50 years of suicide prevention could not do. And within months, the Golden Gate Bridge Authority voted 15-1 to put a safety net under the bridge. Now, they haven't done it yet. They've done the environmental impact study, and they're trying to raise the $50 million it's going to cost. They will do it. Now, in Seattle, the Aurora Bridge, which doesn't get as much press, but it was number 2 behind the Golden Gate, caught on. They commissioned $1.5 million and just did it. They put up an 8-foot barrier on both sides of the bridge. I have a friend of mine, Peggy West, who's with the Suicide Prevention Resource Center. She's a social worker in Seattle. And a woman went to that bridge to end her life. A week after that rail was implemented, she didn't know about the rail. They've always had a phone on that bridge. It's seldom used. She used it because she thought she was finally going to get out of her pain, and she couldn't get over that rail. So she called the phone. She picked up the phone when she couldn't get out of her pain. Now, why have we not understood suicide correctly for so long? I think the predominant reason is twofold. One is we haven't had individuals with lived experience of suicide informing us about it. We've had family members and friends of those who've died. We've had clinicians like myself. We've had policymakers and researchers, and we've all given it our best go. But we didn't get it. Now, why didn't we have them in the room? Well, for a host of reasons, but for one reason, we actually believed there were two different groups. On the one hand, we believed there were those who die by suicide. They're really intent on it. You can't stop them anyway. When they do die, we pat ourselves on the head and said we say we did everything we could do. It was unavoidable and inevitable. Then on the other hand, we have those, Group B we'll call them, who talk about suicide but aren't going to do it. We talk about that they gesture, or they manipulate, they waste our time. I walked into an emergency department at 2 a.m. in the morning in Rome, Georgia, 12, 15 years ago. I was there to assess a 17-year-old woman who had taken a slight overdose. And as I walked in, it took me 45 minutes to get there. As I walked in, the head doc was telling the charge nurse, I just overheard him as I walked in, she doesn't need this, but I'm going to order a charcoal lavage so that I can teach her a lesson about wasting our time. Now, he made that based upon not a psychiatric assessment of her distress, because that was my job and I hadn't asked her a single question. He made that based upon what she did and a belief that there's two kinds of people. Now, there's still top researchers who kind of buy into this. When you ask them, they'll say, well, look at it. The people who die are older, they're white, they're male. The people who attempt are younger, maybe they're female, maybe they're LGBT youth. So it looks like two different groups in the United States. In China, when pesticide, lethal pesticide, was readily available to all, and there weren't the barriers to use as there are with firearms or a bridge, then we faced a very different type of situation in which females died more frequently than males. Group A and Group B. Kevin Hines, some of you may have seen the Kevin Hines story. Kevin was in the Bridge film. He went to the Golden Gate Bridge in 2001, I believe, 19 years old at the time, and the bipolar disorder was wreaking havoc on his life to the degree that he said, I cannot sustain this pain. And he went there to jump off the bridge. Now, if you're on that bridge and you're looking out, it is a spectacular sight. You see Angel Island and Alcatraz and the Bay Bridge and the jewel that is San Francisco. You're 280 feet above the surface of the water. And there's no romanticism to it. Any object that leaves that bridge reaches a speed of 75 miles an hour, hits with 1,500 pounds of pressure per square inch. It's the equivalent of hitting concrete. And most things are driven deep into the water, and many are washed out into the ocean. And not all even hit the water, sadly. It's not an exact science, obviously. Kevin was standing at that bridge. He was aware of how his brain and his body would fight him, would work against his efforts to end his pain. He was crying. He was there for 40, 45 minutes and thinking no one cared. An attractive German tourist walked up to him. And he had just a little glimmer of hope. And she handed him her camera and said, would you take my picture? With tears streaming down his eyes. And he took the camera and took her picture, gave it back to her, and said, I won't say what he said, screw it. And he hurled himself over the rail. Now, he did it because he knew he didn't climb across, stand on the apron, and then have his mind and his body fight back. So he hurled himself across. And he talks a lot about that last 5 seconds. Second one on the bridge would do anything to end the pain that he was experiencing. Second two, not on the bridge, would do anything to be back on that bridge. To have his fingers attached to that firm steel. That everything that seemed so insurmountable suddenly seemed very able to achieve and overcome. And he realized quickly that probably too late for that, but he thought in his mind, maybe I can position my body. He happened to kind of get in the tuck sort of, the same sort of an angle that the very few who've survived that bridge have survived. He hit the water. He was driven 30, 40 feet underneath. It's black. He doesn't know which way is up. His legs are not functioning. He's fractured vertebrae in his back. He begins to just swim for his life, finds a way to the surface. Now, when he gets to the surface, he starts feeling a rubbing up against his leg. And he says, oh my God, my luck. I'm 1% who survives a jump from the Golden Gate Bridge, and now I'm going to get eaten by a shark. Go figure. Now, in hindsight, he believes today, through something that one of the lifeguards, the Coast Guard told him, that he believes that was a seal sent by God to save his life. Go back and read David Rosen's. The 7 individuals that were interviewed, they all read very spiritual, religious, transformative type of facing death that squarely in the eye and surviving. Now, Thomas Joyner in his book goes into other stories that, again, we're over lunch. I'll spare you some. But the one individual who survived the Niagara Falls. Niagara Falls is not a 4-second jump. It's 2 minutes. It's the same thing, though. There is no possible going back. Once you're in the 2 minutes, you are in the 2 minutes. So we have that person's account and the misery that they went through of how they could get back on that landline. There are also individuals who take a bichloride of mercury who almost die and recover somewhat for 6 or 8 hours before they all die. And we have interviews and stories with them. So this group really, to me, not only tackles, but destroys the A and B group. Because that ambivalence that we interpret as they can't be serious, they must be this manipulating, gesturing, attention-seeking. Actually, that ambivalence exists in everyone. We are wired for survival. And if you're trying to save somebody's life from suicide, you always have 2 partners. That person's body and that person's mind. The body itself fights back. It'll clot. It'll take you unconscious. It does not cooperate. We wouldn't be here if it did. The mind also struggles. We're wired. I found myself in a field. It's a long story. I found myself in a field with a 1,500-pound bull that I later learned its name was Trouble one time. And it was like that cartoon where it does its paw and here it comes. And me and my friend, there was a tree about where that black and the bull was over there. We all met at the tree at the same time. And she's behind me with her hands on my shoulders. We're trying to keep that tree between us and the bull. And the tree had a Y in it. I remember at one point I was looking straight in that bull's eyes. I'm like, man, that bull wants to eat my children. You know what that bull saw when he looked in my eyes? He saw the cold calculation of several project meetings we had. You know, she and I sat down and we charted out what we were going to do. And no, none of that. We didn't have time. It was all instinct. It was all fear, flight, or fight. I didn't think through any of it. Not a single conscious decision. You just did. That comes from wiring. And suicide is no different. When we're in jeopardy, it fights back. What we have found is diagnosis is not destiny. Those who've made a prior suicide attempt are at much greater risk. But this ambivalence is there. It's always there. I believe very sadly that some 1,500 times a person has jumped off that Golden Gate Bridge and instantly been willing to trade their soul and everything else to be back on that bridge. But the hope is the opportunity for us to make a difference and intervene in that moment is exceedingly powerful. Our expectations should be far higher. And what we find is diagnosis is destiny, survivors survive. That ambivalence we equate with someone who's not serious is in fact there in those who make the most lethal types of attempts. Polling question number 3. Reflect on this for a moment, if you will, because I'm going to ask for hands. Suicide is most like, if you will, or mark all that apply. I'm going to read them first through and then ask for your, number 1, it's a choice, or A, choice. B, a sign of psychological weakness. C, akin to murder only of the self. D, akin to cancer. Or E, all of the above. So, hands for A. It's a choice. Now, thank you for being honest. Some of you are not raising your hands because the predominant view in our society is that suicide is a choice. So, I think most people believe that. If you don't believe that, good for you. A sign of psychological weakness. Hands for that akin to murder, only of the self. Akin to cancer. And E, all of the above. All right, from my viewpoint, the answer is D. Now, I talk to a lot of people, even in this field, who really, really struggle with that. And for a host of reasons. Let's talk about them. Rabbi Kushner, how many of you have read the famous book, Why Bad Things Happen to Good People? You've read that book? Do you remember the ice experiment? In the book, he uses the psychological research around putting your feet in ice water. You can keep them there so long. And what they found is if you just put another person in the room with them while they have their feet in the ice water, they can hold it twice as long. Just from having somebody, you can endure more pain with human supporting connection. And I started thinking about this when I heard this story, because I heard this story from Major General Mark Graham, whose sons Kevin and Jeff were both in the military when they died, within 7 months of one another. One died when an IED exploded and he was with his team. The other died by suicide. And because this is a public figure, the media and others would come up to him all the time. He was in stories. They would come interview. Major General Mark Graham, tell us about your son who died trying to save his crew. They didn't ask about the son who died by suicide. And he gave this story. And I started to think about, I ran the New York Marathon in 2007. And me and my friend Michael, we had this great idea that to recuperate, we would do an ice bath. You see the NFL players and others do this. Great idea. How many of you have done an ice bath? Tim, you've probably done it. So we got a bathtub, and I put bucket after ice bucket until it was totally full of ice. And then I put water in until it was full of water. And I hadn't done the research on this, so I just got into the water up to my neck. That was what happened on second one. On second two, I said, oh my God. Now, 20 minutes later, Michael said to me, wow, David, you could get out of that bath if you wanted to. And I thought, wow, I hadn't thought about that before. Now, that's not actually what happened. Actually, instantly, sheer terror went through my mind that I was not actually going to get out of that water fast enough, because it was pain like I have never experienced. Now, there has been a view out there that if we talk to someone about suicide, they might get the idea to do it when they hadn't had that idea before. It's a ludicrous concept and very offensive to those who've actually struggled with intense psychiatric pain, because it's like saying that it would have never dawned on me to get out of that tub of ice when that was the only thing that was occupying any of my thought. Every bit of my body and mind was, how do I stop this pain? Suicide is not primarily about dying. It's about ending intense, unsurvivable pain. That's what it's about. Death by suicide is one of the most fearsome. So the essence of Thomas Joiner's theory is that there are internal psychiatric distress issues, a perception of burdensomeness, a lack of connection to others. But there's also a key component that is capability. So that 17-year-old female who came in may have been in enormous psychiatric distress, but not yet capable of getting over that wall. Because her body and her mind, she didn't have the expertise or the courage yet. Now she can gain it. It was her first attempt. She can build it. So Thomas Joiner does an assessment of the capability of an individual. I was at a conference recently where he was talking about, he gave that survey to special forces in the military. And a researcher raised his hand in the back and said, why would you give that survey to special forces? Because they all have the capability in their own life. And he said, that's what the military said to us. But we're researchers, and we decided to give the survey. And what we found is even among those special forces, broad variability in our assessment of their own capability. Because they're human too. And what he said was, what I've found is survival is deep. It's in our cells and it's in our souls. And it fights back. And even some with Special Forces training don't quite have the capability yet to breach that. So psychiatric distress is half the equation. The fearsomeness is the rest. I use that particular metaphor. I was doing one of these mud runner events one time. Tim, have you ever done one of those Spartan race things? I thought it'd be 8 miles of running and some fun obstacles. It was 8 miles of obstacles and no running. And 2 miles in, I've never wanted to quit anything. I was just like, how do I'm going to die. I came up to this 8-foot wall, no handholds, no nothing. I bounced off of that wall. I put my hands down and I said, thank goodness, where's the exit? And right as I did that, this young woman came past me, shorter than me, heavier than me, and she hit that wall with her foot. Somehow she got her fingertips on the top of that wall. And then she took her left toe, and somehow she got it up on the edge of that wall. And I looked, and she flopped over, and she was gone. What did I say? If she can do it, I can do it. I saw her technique. That was part of it, and I did do what she did. But part of it was, and in fact, I think this is the heart of some of the contagion we see. We think someone else at the school got an idea they didn't have before and ends their life by suicide like a peer or a friend or someone else. No, I think they didn't know how to get over that wall, and suddenly they realized they might be able to get over that wall after all. What are the implications for health systems? Another poll question. The risk of death for those with serious mental illness. I'm going to cut to the answer. You know, we think of high risk being veterans and military and certain ethnic groups and LGBT youth. If you take the risk of all of those groups and lump it together, that's probably the risk of those with serious mental illness. Various research studies have found 12, 13, 15 times greater than the general population. Very significant risk for those who have serious mental illness. Major depression, schizophrenia, bipolar disorder, borderline personality disorder. Most professionals in the country think they gesture and manipulate and make attempts but are not at risk. They may gesture, manipulate, and make attempts. They're also at risk greater than or equal to those with major depression and schizophrenia. Those with eating disorders at very significant risk. Richard McKeon, branch chief at SAMHSA, said this: over the decades, individual mental health clinicians have made heroic efforts to save lives, but systems of care have done very little. So we now have a national collaborative that we invite you to join. You can get to the website zerosuicide.com. It's a national set of innovators in Arizona, Texas, Kentucky, New York, Utah, who am I leaving out? Tennessee and Indiana right now, who are all partnering together to bring heroic efforts to systems. I ran a system for the last 5 years in Phoenix, Arizona. We collaborated to develop how could we, Mike Hogan, many of you may know him from the President's New Freedom Commission report, how do we do the same thing other fields have done, healthcare fields have done, to make suicide a never event? How do we bring the robust performance improvement that medical systems bring to wrong site, wrong patient surgery or infections? How do we begin to use those things in the world of zero suicide? Zero suicide was inspired by Zero Cancer. It's an initiative of the Prostate Cancer Initiative. 35,000 men a year die by prostate cancer. Nobody even thinks anything about zero cancer because they believe prostate cancer is treatable and death is preventable if treated early. The Air Force, back in the late 90s, had a very significant difference in outcomes from a cultural, leadership, social intervention around suicide care at the systems level. The Henry Ford Health System has had dramatic results. Now, they're a Malcolm Baldrige Quality Award winner, but they've taken their robust performance improvement, applied it to suicide, and I encourage us to look at our own systems. Is suicide care at the core mission of your agency, or is it secondary, or is it more on the periphery? For us, suicide care and systems framework is a new approach where we're bringing this to the core of what we're doing. Suicide isn't something that is referred to someone where we need a mobile crisis or a psychiatrist or law enforcement to take the person to an ER or somewhere else. It's something that we engage in discussions with and support at a case manager or peer or clinician or social worker level. Lots of groups are making progress on this. The VA has really under enormous pressure, the Joshua Omvig legislation about returning veterans, but they've done some really amazing work, as well as the Joint Commission around patient safety and the National Suicide Prevention Lifeline. I'm going to skip that. TEROS is an agency that's probably not dissimilar to your agency. Some of you actually may know TEROS out of Phoenix. Anyone here had interactions with Peggy Chase or Dale Reinert over time? Their organization employs about 550 staff. You see the composition on this screen. Social workers, case managers, physicians, nurses, peer staff, billing staff, etc. We did a survey of those staff, and actually a survey of about 2,000 back in 2009. That's the survey that now we've done across 9 states with 30,000 responses. And what we found at that time was that about 11% of their staff had been trained in suicide care. If we flash forward 3-4 years later, 81% of their staff have been through training because they've basically provided that training to everyone. Basically what they found, in short, is that prior to that training, when you ask staff to self-report, do you have the skills? Do you have the supports? And do you have the training to engage those at risk of suicide? In the United States, you've got basically a coin toss chance that they're going to at least agree to those 3 questions. So our whole suicide prevention initiative in the United States is built around gatekeeper training like mental health first aid or QPR to identify those individuals who are at risk and get them to behavioral health specialists where you can toss a coin, and if it comes up heads, the staff will self-report. They can do that. And if it comes up tails, they'll self-report. They don't know how to do that. They don't have the supports to do that. There are very simple, a host of, I'm not selling any one training. There's a host of different approaches out there. Basically what we find is when there's some core training that's provided to staff, their confidence, supports, and self-assessment goes up dramatically. And those who believe they don't know what they're doing go down dramatically. This is the number of states and the surveys. I'll just draw your attention to one thing on this particular page. Over 6,000 have reported they've had someone in their care die by suicide. And more than half that time it's happened more than once. And guess what we find about individuals who've had someone on their caseload die by suicide? Guess what kind of reaction they have? A human one. They grieve, they blame, they're angry, about 30% of the time it's very intense, and we have people leave the field because of these experiences. So, when we very first started this, the National Action Alliance put out a paper, Suicide Care and Systems Framework, and we said we need early adopters to put this new model into place. And then we quickly realized we don't have a baked model yet. What we have is a series of essential principles and guidelines, and what we need are a set of innovative partners across the country. So we now are having that sort of developing. We have an advisory board for zero suicide, and we have a learning collaborative that takes place on a monthly basis with all of those states that you saw earlier participating, and we're pooling all of our resources on zerosuicide.com. The final thing I'll leave you with is that where we started was, I think our view of suicide today has been dramatically changed by those with lived experience. Eduardo Vega is one of the top leaders in the field. He heads up the Mental Health Association of San Francisco, and he said this: suicide prevention has not been informed by peers who have experienced the agony and decision-making. They can provide support, and that can be the magic. And I believe you will find, as you tackle this in your own organizations and look to make this a core mission, that zero suicide and dramatic changes can be in the future of Missouri as well as other parts of the country. Thank you very much.